So, Dr. Vishal, all ready?
Yes, sir.
Your voice is echoing.
My voice is echoing. Why?
There must be some gadget which must be interfering. Are you on two gadgets simultaneously?
No, sir. Only one. Still, my voice is echoing.
No, now it's fine. Now it's fine.
Yeah.
Okay.
My phone was near the desktop.
That may be the reason. Okay, we'll start, right?
Yes.
Good evening, everybody. Welcome to this evening episode of Pursue. And we have Pursue 1L, which is Uropathology. And we are streaming live from BIA Cancer Center, Hyderabad via Kolkata. And we have a very special person today and speaking on a very special topic. And the topic is very nicely worded by him. The topic goes as, hello GU, what's happening? Grossing to reporting, which is the part 1, which is kidney and prostate, and handle with care, of course. And to talk on that, we have none other than Dr. B. Vishal Rao, who's a postgraduate in pathology and DNB pathology, DRCPath from London, UK, Post Doctoral fellowship in Oncopathology from Tata Medical Center, Kolkata, observership as a Post Doctoral fellow from Hopkins Hospital, Baltimore, USA. He's presently as a senior consultant pathologist in Basavatarakam, Indo American Cancer Hospital and Research Institute, Hyderabad, a very famous institute, and I have had the honor of visiting that. And he has a special feather on the cap, as he is a visiting fellow scientist as an IARC editor for the upcoming WHO classification of urinary systems and male genital organs in its 5th edition. So who better than him to talk on GU and to talk to us on various aspects of GU, right from grossing to reporting. Before I ask Dr. Rao to take over, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Vishal Rao, sir, please share your screen and start. The stage is all yours.
Can you see my screen?
Yes, sir. Your screen is absolutely clearly visible and your voice is very, very clearly audible. Please start, sir. Thank you.
Yes. Good evening to all. Good evening, Dr. Nadeem, and I thank Dr. Nadeem and Dr. Divya Madam for giving me this opportunity for presenting this presentation. And my presentation, this is part 1, in which I will be including grossing to reporting of kidney and prostate. And part 2, later part, I will be discussing urinary bladder, testis, and penile cancers. So, why I have chosen this topic is that day to day in our pathology practice, we face a lot of problems, and the PG students who join us as freshers and the seniors also, how to gross the specimen, because always I tell my PGTs that grossing is the most important station, because if you do the grossing properly, your reporting becomes very easy. So with this notion in our mind, Let's move ahead. So first I will take kidney. I'm not saying as an update because I am working with the WHO this year, and the update will be coming at the end of this year when we will see a new WHO book. So this is just a review and what we have been doing all these years in grossing of the GU samples. So first we'll take kidney. So renal cell carcinomas, as you see the history, that earlier it was 9 entities, and before that it was just granular cell and non-granular cells. And later in 2015, the last update, we saw an emerging so many many terminologies and many cancers. And now we have to see in 2021 how many new entities have been added. Definitely, this is the last update of the kidney tumors. This is the list of those 50 tumors. So many tumors will be changed, and many tumors will be added. We will be seeing in the latter part of this year of 2021. So just before going into the grossing, we should know what are the changes which was made, so that accordingly we can do the grossing. So first was the changes were identified as tumor morphology. So depending upon the morphology, many changes have occurred, and addition of sarcomatoid and rhabdoid differentiation was added. The percentage you have to mention because it directly affect the prognosis of the tumor. The tumor necrosis, here also you have to write the percentage of tumor necrosis, and you have to gross tentatively. Because if you gross the entire necrotic area, you will end up saying that 100% of the tumor is necrosis. So you have to take different grossing from different areas. Then grading, major change was there. The time tested Furman grade was replaced by the ICEP. And WHO also approved it, so it is called as a WHO ICEP. It is just not the ICEP, just not WHO, but both we have to include. And microvascular invasion as a potential prognostic markers. These were the main changes which occurred in the last WHO. So we will see how to gross the specimen, final report, or how to report it, and what is the clinical significance of this. So before grossing, you should know the relevant clinical history. Like what are the clinical diseases, whether it is an upfront case or it is a cytoreductive surgery, and other radiological details like size, site, extent of the disease. Then accordingly you will cut the specimen and see, okay, where is the extension. Accordingly you will gross the specimen. Also, prior diagnosis, in our centers we are very lucky that we get very small biopsies because they are required for tumor diagnosis. So if there is a already diagnosis done and ISC has already attempted on small biopsies, no need to do unnecessary ISC on the larger specimen. And prior treatment also is very important when there is a extensive T4 tumor, chemotherapy has been given. So there may be many chemotherapy induced changed, and sometimes you will not see a tumor at all. So that is why prior treatment is also required. And this is the most important point, that is communication with the surgeon or the treating clinician is very important in case of any discrepancy. So the type of specimen which we receive, and usually you may also receive, are the renal core biopsies. The partial nephrectomies which we receive are either robotic or laparoscopic or open surgeries, and radical nephrectomies which can be upfront case when the size is less, and depending upon the clinical features, it can be a cytoreductive surgery, but just they have to reduce the tumor burden, or it can be a post chemo where their size has been shrunken by the chemotherapy and then the surgery has been done. So first we'll see the renal core biopsy. So core biopsy, basically it is done to find out whether it is a reactive condition or a neoplasm. Many a times we see patient presenting as a vague mass or lump in the kidney, and to assess the nature of the lesion, many times the clinician does the biopsies. We have also seen these cases, xanthogranulomatous pyelonephritis presenting as a vague lump, interstitial nephritis due to infection, and malakoplakia, not even in kidney. In other cases also we have seen in colon also, in bladder also, where they present as a mass and they just mimic any malignancy. And if there is a malignancy, further can we subtype it or not? and whether to find out whether it is a metastasis or any non-epithelial neoplasm. So what are the practical problems which we face in core biopsy when we get? Basically, what I face is where a mixed morphology when I see both clear cell morphology and papillary pattern. So is it a clear cell RCC or is it a papillary RCC? Then oncocytic. Nearly all most of the tumors in renal cell tumors, if you see renal cell carcinomas, they show eosinophilic cytoplasm. So this is a very important problem. And the high grade tumors also, where they have bizarre nuclei and we don't know, they don't show any specific morphological feature of any definite RCC, then it is a problem. So if you can see on the left side, you can see the tumors all are showing eosinophilic cytoplasm. But when you try to do ISC, like AMCAR was positive, it was the first one is the papillary renal cell carcinoma where AMCAR is positive. Then the second is CD10 is very diffusely positive, showing a clear cell RCC. Then this is an oncocytoma which is supported by focal positivity of CK7 and a chromophobe with a distinct cell membrane showing a diffuse positivity of CK7. So those were the problem for the renal biopsies. So most of the time we were able to solve the problem. So but again, when in a biopsy, I told that it is an oncocytic neoplasm. But when I spoke with the clinician showed that the tumor is very big and it is infiltrating into the renal vein. It could not be an oncocytoma. Kindly review it. So then we did ISC and we found that it wasn't an oncocytoma, but it was a type 2 papillary carcinoma. So that is why whenever there is a discrepancy, better to talk with the clinician and then work accordingly. Now coming to the partial nephrectomy. So partial nephrectomy, when the surgeon does partial nephrectomy when the tumor size is less than or equal to 4 centimeter. But in our center, I have seen a little bit bigger tumors also where they are polar tumors which are hanging outside. Even if they are more than 4 centimeters, they can do it. And usually done for a benign oncocytoma or angiomyolipoma, which we have been biopsied or looks like grossly. So how to process this sample? So partial nephrectomy, how to process this sample? So any specimen, same rule, you have to weigh and record the dimension. All the 3 dimension you have to mention. You always look for external surface, because whether it is smooth or if the tumor is infiltrating or is there any tumor deposits on that. Also inking the raw surface, because in a partial nephrectomy are mostly done for polar tumors. So there will be either at the upper pole or at the lower pole. Even if it is an interpolar tumor, then you will have a raw surface as one side and the other surface will be covered with fat. So whatever the raw surface is, you see, as soon as you see the raw surface, ink that raw surface in a little bit, let it get dry. So both and cut section, and then along the raw surface you cut the specimen. And usually we get partial nephrectomies in frozen sections, because the surgeon wants to know that whether he has got a clear margin or not. And fixation is also done later. If frozen section is not there, then you have to cut around the raw surface and keep it for fixation in 1:10 ratio in NBF. So this is the specimen of partial nephrectomy. This is what I was talking about. See, the raw surface is there and the other surface is, it is a interpolar, this is a polar upper pole tumor, and see the upper pole, the perinephric fat and genitofascia will be there. And this is the raw surface which you have to ink. Better to ink with black color. And then after that you cut perpendicularly. So after cut section, you can see this is the ink surface, this is the capsule, this is the tumor. So definitely when you are doing a frozen section, you have to give and make sure that you give a good section, because in frozen section, if you give a haphazard section, cutting may be a problem. So what are the key to sections? So this I request all the PGTs to, this is a very important slide for all the sections. Key to sections we have to give. So what are the key to sections? Tumor with capsule and parenchymal resection margin, 2 to 3 sections we have to give. Non-necrotic, if usually it is non-necrotic only in partial nephrectomies. And tumor with adjacent kidney, 1 section, and perinephric fat and genitofascia. These are the sections you have to give. Not more than 5 sections are required in partial nephrectomies. So tumor with so this you can see tumor with capsule and the native kidney, and you can see clearly clear cell morphology is there. So this is how you record your findings. You always mention the clinical history or specimen. Always mention first the laterality, the specimen, again the laterality, and the whatever procedure has been done, partial nephrectomy or radical nephrectomy. So this is the exact, because this is a very important information, medical legal information required maybe later. So you should always tell the laterality in any organ, and in this also. The gross findings also you have to record what is how you have received the specimen, what is the measurement of the specimen. Then after cut section you found the tumor, what is the size of the tumor, and how far is the resected margin, and you have given representative for the same. So this is how you record a gross finding. Then you, after seeing the slides, you can record your microscopic findings. I request all the PGTs to be very specific. Don't write lengthy half of pages descriptions. Your main aim should be like how you see in the microscope. In a scanner view, you just tell what is the morphology, how the tumor morphology is, whether they are in sheets, whether they are their nests, or how they are, and then the individual tumor cells, how they are looking. So this is the final impression which we give. Then again same laterality and the specimen and the organ. Then you have to write clear cell, renal cell, and you have to give the grade. WHO ISEP grade. In partial nephrectomy, what are the important points to be written is the size, LVI, any abnormal features are there, and this renal capsular and parenchymal margins are free of tumor. This is the main point which is the surgeon is also looking, and perinephric fat general fissure, if they are present, you have to mention. So whenever, always I tell, whenever you are reporting the partial specimen or a radical specimen, always report like a clinician, because this is mainly for the staging of the tumors. So always first this report will be read by the surgeon. So he will be concerned about the size and the margins. Then again it will go to the medical oncologist. Then they will also see what are the other features, what is the morphology, what is the size, what is LVI, is there or not, and how are the margins. And then radiotherapy people also, if possible, they will also see the report. So after partial nephrectomy, let's see the radical specimen, how to do the grossing for radical specimen. Same radical specimen, if we see that we receive kidney, ureter, most of it, renal vein, artery, perinephric fat, surrounding gerotous fascia, and adrenal gland can be present. Again, processing of the sample will be same, weigh the specimen, dimension, external surface you have to see, and cut section, again localization, size and extension of the tumor you have to see. And proper fixation is very important in this all the specimens. You have to fix in 1:10 ratio, and try to, whenever from the OT you see, when you receive the specimen, the jars may be not appropriate for. So better when you received a fresh specimen or specimen in a jar with formalin, try to change a fresh formalin, and after fixation, after cutting, and keep it in a bigger jar according to the specimen, so that 1:10 ratio of formalin fixation is maintained. So these are the specimen which we receive. You can see, so when you cut it, better to cut it first in the half along the hilum, and then you can serially slice the tumor so that the better fixation is there. And again, on cut section, you have to mention what you are seeing. Any scarring is there? What is the color of the tumor? And is there any necrosis is there? And what is the extension? Can you say if you identify if it is going into the perinephric fat or renal sinus fat? So these are the factors which you should look. So this is the most important slide. I want your attention on this slide. If you are not paying attention to the other slides, but this is the most important slide for the kidney one, because here we are seeing that we have cut open the kidney. You can see there is a one tumor, gray white tumor is there, and then what are the sections you will give in this? So tumors. So I always tell sometimes some people will give tumor section differently, and then they will give gyratosis fascia, perinephric fat. Don't give like that. If you give a section from here, you will get the gyratosis fascia, perinephric fat, and the tumor in one section. So basically, from different you have flaps of different flaps you can give from different places. Like from one flap you can give here, the second flap you can give from here, and third flap you can give from here. So definitely the tumor is going into the perinephric fat. So if you ink the surface, so gyratosis fascia involvement is there or not, we will know. So definitely this will be there. Then so ideal tumor sections in any radical specimen, they say 3 to 4 sections from non-necrotic area. Definitely you don't you have to sample necrotic areas, but for the tumor assessment, 3 to 4 sections from the non-necrotic areas have to give it. Second, other sections what you have to give is the tumor with renal sinus fat, tumor with hilum, and tumor with adjacent kidney. 1 and 2 sections can be given. And renal artery, vein, and ureteral cut margins have to be given separately. And again, lymph nodes, if adrenal is present, you can just give adrenal, and if lymph nodes are there accordingly, and also try to look for lymph nodes in the perihilar areas and in the perinephric fat. So these are the key to section for radical specimen. So tumor with capsule, perinephric fat, and gyratosis fascia. We have to give 3 to 4 sections from the non-necrotic areas. Tumor with renal sinus fat, tumor with hilum and renal pelvis, tumor with adjacent kidney, renal artery and vein margins, ureter cut margin, normal adjacent kidney, and representative section of the adrenal. So this is how we try to record our findings. Again, same clinical histories, specimen, again as I told you, laterality, the specimen, and then again laterality, what is the surgery done. In this case, it was an extensive tumor which was adherent with the colon also, which was infiltrating the serosal surface of ascending colon also, and IVC thrombus was also there. So again, you saw that you have to record all the findings. What is the size of the kidney, ureter, adrenal, gyratosis fascia, number of tumors and dimension of the tumors, what is the site, description, invasion, where it is invading, how far is the ureter, how much is the length, and how far it is, and any other findings which are there you have to tell. So if we see microscopy, most of the time it is very the common tumors you see clear cell RCC, where you see the clear cytoplasm, papillary RCCs, AML also we saw not many cases, but angiomyolipoma cases are also there. Chromophobe, where distinct cell membranes is there, is also seen. So this is how you give your final impression after seeing the morphology. What is the type of tumor, what is the WHO ICEP grade, what is the location, size, extension. If it is limited to kidney, is it not invading the renal sinus fat, you write limited to kidney. And then LVI is there, necrosis is there, sarcomotor differentiation, how much percentage you have to give, and other findings which you had margins, and if any other findings are there, you have to record. And again, then IVC was also sent in this patient in a separate container. So sarcomotoid and rhabdoid differentiation are very important, because they tell the prognosis of the patient. So sarcomotoid with fascicle of malignant spindle cells. Rhabdoid cells are also seen in association with chromophobe RCC, and they are basically large epithelioid cells with you can see central eosinophilic intracytoplasmic inclusions are there. Tumor necrosis is also very important, and you have to give the percentage, and as I told you, you have to be you have to identify the different tumors areas. If you try to give more from one area only, then you end up giving maximum necrotic areas only rather than the tumor itself. So grading of the tumors, As you see that now Furman grade is not used, the WHO ISEP nuclear grading is seen, and more or less I found it is very similar, and grade 1 and 2, 3, 4 grades are there, and more or less it looks same. 1 to 3 depends upon the presence of nuclei at different magnifications, and grade 4 is again bizarre cells and sarcomatoid differentiation is there. And this is an important point that chromophobe RCC, it has to be not to be graded. So when you are writing chromophobe RCC, that's it, don't grade it. So we have seen how to gross it, how to report it, but what is the problem now? So practical problem which I am facing is, again, morphological cocktails still exist in larger specimen also. High grade tumor, we don't know where to put them. And breaking the ISC codes, if you see, again you can see these are the sections from the radical specimen. Again, same morphology and eosinophilic characters, and they may look very features may look very benign, but the outcomes, they may look same, but their outcomes are totally different. Both are cats, but the result is totally different. Even grading also, some may say it is 3, some may say it is 4. So there may be a discrepancy between subjectivity can be there among pathologists. So, and if you see, you want to try to solve this problem with ISC, you can see so many ISCs are there. So how to go about it? How to break this matrix of ISC? So you see papillary carcinoma, CK7 is positive, you are very happy, and then you do the panel and you see CD10 is also positive, and you said what? And then oncocytoma CD117 is positive, CK7 is occasionally positive. These cells may be positive in the scar areas. So with this problem, seeing these problems, what I try to do is I try to make a concise panel which is helpful, which is very concise, and which is cost effective, which can be used in all the patients. So if you see this panel of 4 markers we used, and we found to correct almost 98 to 99% of the cases, solve those cases. We did a proper study and we published this in urology annals, and it was published last year. So with these things in mind, so we have seen the grossing, the reporting, and what problems we are facing and how we can overcome the ISC. So I'll share 3 cases of rare and interesting cases from our department. So this case, one is a 37-year female with left renal mass, and she had a vague palpating mass, vague mass. So this was the when we received the gross specimen, and very brown, mahogany brown, you can say that color is a very well circumscribed but very big tumor. So this was the morphology. It was looking very benign, and but the size was very huge, and all the cells were showing eosinophilic cytoplasm with round to oval nuclei. CD117 was very much positive in this case. Surprisingly, some areas CK7 was also positive. So other ISC which we did showed negativity for CD10, AMCAR, and Mymentin, and cyclin D1 also was very focal positive. So when we checked into the latest WHO guidelines, so it was a renal cell carcinoma, unclassified, oncocytic, low grade type. So we searched for the references. It was an unclassified. Basically, it is not a distinct type of RCC, but a diagnostic criteria for tumor that really do not fit into any recognized subtypes, and it can be low grade and high grade. And these tumors accounts for less than 5% of RCCs in reported series, and the patient range from 21 to 91 per years, and about 50% of the reported cases occurred in men. And mortality, however, the mortality rate is higher than the routine clear cell RCCs. and usually large. They are usually large and involve extensively involve the kidney, like in our case, and have a more than 50% cases have diameter more than 7 centimeter, and feature does not resemble those any well characterized RCC, and so tumor that may be included in this criteria are combination of features are there of more than one recognized subtype or unrecognized epithelial cells, lower high grade unclassified oncocytic neoplasm, and other unclassified tumors. The genetic profile is limited because they are very rare cases, and these tumors tend to have marked genetic instability. So prognosis, as we saw, that it's not good, and again high grade features have a bad prognosis. So second case, it's a 49-year-old male presented with abdominal lump and pain since 2 months of duration, and we found a large abdominal mass on the left side crossing midline. So this was a tumor which recently we got 2 months back, and these you can see a large tumor and replacing the entire kidney, and different areas are there, and these glistening gray white areas are also there. So when we saw the H&E, you can see definitely the epithelial cells are there which have distant cell membrane and eosinophilic cytoplasm. Few have clear cytoplasm, and we saw bone also, and we saw this atypical cells which were more of spindle like this, spindle cells, and which was haphazardly arranged, and this spindle cell component was like 70 to 80% as compared to the epithelial component. This is the epithelial component. This is the bizarre component, cell component. So when we for the spindle cell component, we did SMA, which was positive. We did Cal-Desmond, which was beautiful co-positive. This is the, I think, very few cases I have seen this much positivity for Cal-Desmond. CK7 was also very much positive in this case, and CD117. So if we see the ICs which I used my panel of CK7, CD117, and MCAR along with the spindle cell because of the morphology. So we made a diagnosis of chromophobe RCC with predominant leiomyosarcoma component of 80%, with osteosarcoma and chondromatous differentiation was also there. And at the time of diagnosis, the patient also had lung metastasis. So again, we thought that because the percentage of sarcoma is more, so we labeled this as sarcomatoid chromophobe RCC. But according to the experts, when I discussed this case, and WHO when we referred, so basically whatever the percentage of the sarcomatoid percentage, you have to write as a component only. You have to write the epithelial component as a primary tumor. So in this, then we change our diagnosis to chromophobe RCC with predominant leiomyosarcoma component 80%, with osteosarcomatous and chondrosarcomatous differentiation. And a little bit of literature for this. About 35 cases of this sarcomatoid RCC was with heterologous elements have been described. So far, 12 cases with sarcomatoid chromophobe containing heterologous elements have been reported. And DDs for this include a classic sarcoma, sarcomatous urothelial components. His spindle cell component is predominant. And additional primary sarcoma should not contain epithelial component. The patient currently is on TKI, sunitinib, and 7-week follow-up is there, which is uneventful. So unclassified RCCs and sarcomatoids are aggressive and present with rapid disease progression and poor prognosis. And awareness, aggressive treatment strategies, and close surveillance are required while evaluating the patient in multidisciplinary team meetings. The last case is a 37-year female. We came with a complaint of decreased appetite and distension of abdomen since 20 days. When she was evaluated in our hospital, it was found that she had a very big, large tumor of 19 centimeter, and in the right lumbar and right iliac fossa with mass effect was there, loss of flat plane, which infiltrating into the kidney. And excision was done, and now she presented with metastasis also. So this was a morphology. If you see with the gyratosis fascia, this section what I was talking earlier, if you give, this is the ink, you can see this is the gyratosis fascia, the perinephric fat will be there, capsule will be there, the tumor was there. So when I saw this morphology, I was very happy because if you can see in high power, many fibrous septa there, fibrovascular septa are there, cells have clear cytoplasm, and these are the cells. Few cells are elongated also, and many cells have eosinophilic to clear cytoplasm. So I thought the clinician called me. I said it looks a very clear cell to me, but I said okay, let me do. He said you can do IC. So I said I'll do IC, and we did CD10, which was negative. CK7 which was negative, and other markers we did vimentin, which was negative. So again we said if it is a clear cell, why all the markers are coming negative? We re-looked into our morphology and we saw some bizarre cells, and then we saw some thick blood vessels also. So could it be a we did a HMB45, so could it be a angiomyolipoma with a epithelioid predominance? So HMB45 was positive, melanine was positive, as S100 was also focal positive. So we labeled this as epithelioid angiomyolipoma. This was a case some time back when WHO was new, so I thought I wrote as new. So these were the cases. So so still we are juggling with the HNE, ISC and molecular markers, and our new classification will be if not now, in future it will be molecular driven, and basically it will play a major role. But still I think at this moment HNE and ISC plays a good role in diagnosis of renal cell carcinoma, and a main key to this is proper grossing, proper handling of the specimen. And what I tell to my PGTs is, if you do proper grossing, your more than half of your reporting is done in the grossing room only. So better to know the stage of the tumor and what are the sections. If you know, you can write down the sections. Okay, these are the sections we have to give again, and where we have to give. We have to find out where are the areas, like not giving many sections from the necrotic area. Try to give sections from different areas, and for proper staging. And you remember the radical specimen are for proper staging. So whenever you are reporting, you should report as a clinician, not just like a pathologist. You have to report like a clinician, because at the end of the day, the report has implication on the treatment and prognosis of the patient. So a lot is happening. We asked the question, hello Gio, what's happening? So I ended with a lot is happening. We have good way to go. It's our hospital. So I'm ready to take some questions for.
We have some questions and some queries, and we have a lot of experts in the panel, in the audience, who would like to give their comments as well.
Yeah.
So let me first read out the question in the Google chat, which is by Dr. Kataria. He says, is core biopsy recommended in RCC?
It is not recommended, sir, usually, but in our center we do because of some reasons we do it here.
Okay, so it's not recommended. What are the chances?
The recommendation is not there.
Okay, what are the chances of tumor dissemination if we are doing core biopsies? I mean, Dr. Kataria's continuation of the same question.
In my experience of this in this hospital, I have not seen any dissemination by biopsy, even repeat biopsies also. Usually it is not there as compared to other organs like testis and all.
Okay. So let's wait and see if there any. Dr. Sambit Mohanty is there. He would like to make a comment.
I will love to. Yes.
You can unmute and straight away go ahead.
Hi Dr. Nadim. Hi Vishal.
Hello, how are you?
Welcome. I'm good. Happy New Year. So,
same to you. Great.
So Vishal, great job. Just to add a few things to your thing, like the dissemination by needling or by doing a core biopsy in renal cell carcinoma, really doesn't happen, and a lot of centers across the world they're doing it. It's a very good procedure, because Vishal has already pointed out very clearly in one of his slides, I like that, like for low-grade tumors, or when you have like xanthogranulomatous inflammation or something which is mimicking on imaging, and it's difficult to differentiate from a low-grade carcinoma. And secondly, renal cell tumors, they do not have a very high proliferative index. We normally do not do a Ki-67, But if you do it, other than the cases with sarcomatoid DDIF or high grade like a CDC or MC kind of categories,
If
you
you
will
stop
get.
presenting, then we can see Dr. Mohanty. We can't see him. Just stop presenting.
Wait.
We'll be able to see him. Yeah.
I am actually sitting on the floor.
Doesn't matter. No, doesn't matter. Doesn't matter. Just stop presenting. Just just go to Google Chrome. Just go to Google Chrome. Press Google Chrome on the taskbar, and
Yes.
you are stop presenting. Just press stop presenting
Yes. Yes.
on that. Yeah, great. Yeah. Yes, Dr. Mohanty, comment.
Yeah.
So that is a good. I mean, that's a good point. What people ask, but Vishal pointed out very clearly. Normally, the core biopsies are done when the urologist or the imaging experts are not clear whether we are dealing with a cancer or not. And number two is to differentiate it from sort of a dicey inflammation like glandogranulomatous inflammation, which mimics closely to a cancer. And I have to add a few things there, like in core biopsy, as Vishal said, in oncocytic neoplasm, most of the time we end up calling it as an oncocytic neoplasm. It's difficult to name it, even if it is diffusely 117 positive. If it is CG117 diffusely positive, we can say like we are probably in the oncochromo group. But I would prefer to call it as a oncocytic neoplasm because I do not want to lose my patient. Once I say oncocytoma on a core biopsy, the patient is not going to come for follow-up. And later on, he will come up with a metastasis, or she will come up with a metastasis. So the basic job for the core biopsy is not to call something, I mean, which definitely grading is not the question. The question is we need, what is the next step? So as a pathologist, like a clinician, we have to think two instances. When you are looking at a resection specimen, we think like we are treating the patient, and when you are looking at the core biopsy. Because once we say like there is no cancer, it's oncocytoma straightforward, the patient is not going to come for this. And so RCCs, they are known to have a very rich inflammatory stroma, like lymphocytes and plasma cells and xanthoma cells. Sometimes in core biopsy, they give a very deceptive look of a xanthomatous inflammation. The more and more coming up in the new WHO and all. So that time also I'm a little skeptical to call like whether. And another instance is when you have a very cystic change. I mean, you see one corner of the biopsy has a cyst with some cells on H&E. And they look very, very inconspicuous in H&E stent. You do a PAX8 or a CK7, the cyst is going to light up. So in that case, definitely you are not dealing with non-neoplastic process. So it's basically a good screening technique, and I like it. I mean, I like the core biopsy concept.
Yes.
And regarding the margins in partial nephrectomy specimen, we do get that from the urologist, but the studies across in the Europe and the US, they have shown, like even in India, I asked the urologist, if I say the margin is positive, are you going to give me more margin? They said no, because they do a fulguration technique. So by that, and it's a round thing, it's a concave thing, convex thing. So even if you kind of say it is positive, it is not like breast or any other organ, they don't give you more thing, and the patient really, they do well. And recently I had a case which I said like a year and a half ago, I said the margin was positive, and the patient developed some chronic renal condition, and they sent the tissue to me, and there was like a scanning and all the biopsy related changes at the margin side of the total nephrectomy, but there was no tumor, and the patient did not get any adjuvant treatment for that.
So when the surgeon is sending a frozen section, so Rakesh will call me, the surgeon will call me and will tell that the tumor was used when they try to cut the margin, the tumor as you said, the tumor tends to bulge.
Yes.
So they have to remove the tissue, but as the tumor bulges, there may be a cut.
Right.
So it is not a margin is positivity. So that is what I'm saying. Clinician correlation should be there, and communication with the clinician should always be there whenever there is some discrepancy. When you see the tumor is cut and whatever any discrepancy is there. So that is the key.
That's a key, yeah, absolutely. And one thing is, in our setup, like in India and all, we cannot tell every patient to like go for immunostain in RCC. So we end up calling something as unclassifiable RCC. And before we try to name it, it's always better to talk to the clinician. What is the clinical repercussion of that? Whether he or she is going to change the treatment of the patient.
Yeah.
Because most of these new evolving entities do not have their specific genomic repertoire and a specific target in them. So in that scenario, it is kind of always good to have a clinician, an interaction with the clinician to
Yeah.
have some.
Because in the epiploid AML, our clinician gave them mTOR rapamycin they gave,
Okay.
and patient has skin lesions also at that time.
Okay.
And responded well to the treatment.
Great, great. Yeah, because mTOR inhibitors are kind of, they are FDA approved.
Yes.
And either the sunitinib, the VEGF inhibitor or the mTOR inhibitors. And also, and how do your clinician, do they ask for PDL1 for these cases? Renal cells, metastatic renal cells?
They are asking.
They're asking. Yeah, that's something very, very upcoming and has a lot of papers coming up and a promising value when they're in renal cell. And renal cell is, some of the renal cells, the low grade ones are good disease, like the LOTs, low grade oncocytic tumors.
Yes.
And chromophore is a good tumor to have with though it looks. And chromophore sometimes is very, very tricky. You do not get the perinuclear halo and the wrinkling all the time. So that is one area. Do you do immunostain for all your oncocytomas, even if it is classical? I know the answer what you're thinking, but I'm just asking.
In the radical specimen, definitely I won't do it because I have the specimen pentile. But in biopsy, I'm very much skeptical.
Yeah, biopsy you'll definitely do. My question is, you have a classical oncocytoma. You do not, I mean, it's like a no-brainer oncocytoma. Will you go for CK7 and CD117? I know you are a geopathologist, so for that reason I'm asking.
Ideally, we should not take any risk.
Yes, I got your answer. I mean, ideally, because this LOT thing is kind of coming up, where they,
Yes.
I mean, typically oncocytomas have very little CK7 positivity, they're never zero, and CD1 is brightly positive, but there's an entity coming which is already there, which is CK7 diffuse and CD117 negative, and looks like more or less more like oncocytoma than chromo. And we recently did a
just completed our meeting.
Yeah.
Yesterday only, and many changes I cannot tell now. Many
I
changes
know,
have.
but but I'm glad, like you said, you don't want to take the risk, so I got the answer. I mean, at least we both are doing the same job.
Yes.
Great.
There is one more question. There is one more
Yes.
question
Yes,
which
sir.
I would like to take before we go to kidney. That is, we will go to prostate. That is regarding the sampling of the attached adrenal.
Yes.
Whether the adrenal should be sampled separately or in continuation with the gerota and the tumor.
Like my case, it was very much adherent with the tumor only. So better to take, if it is adherent, better to take a continuous section, because if it is a continuous involvement of adrenal is there, then it becomes T4, and if it is a separate involvement is there, non-continuous, then it becomes metastasis M1. So that is very important. So if the adrenal is very much in close proximity and attached with the tumor only, better to take the section with that only.
Right. Great. So that was one query. So
We'll move to prostate.
Dr. Mahanti, hang on. You should be here.
Yeah, I'm here. Thank you.
Right. It's nice to see you.
Can you see my screen now?
Yes, please. Fragile.
Okay, so my favorite topic, and grossing of prostate, very peculiarly it has been done, and again, why we are so much worried about this crossing of prostate and reporting of prostate? Why are we putting our heads? Because as earlier it was thought it is a disease from the West. But if you see Indian cancer registries, now it is increased from 0.14 to 8.6%. So, and this is a little bit older, I think 1 decade older data which I have put. But again, if you see, it is on increase because of more of urbanization, increase of change in lifestyle, and PSA levels have been checked more commonly now. So that is why the increase in prostatic carcinoma which we are seeing in Indian population also, and basically this is an exocrine gland which is 20 grams approximately. So why it is important to know the anatomy of the prostate? Because of the prostate have these different zones. The two components are there, the glandular and the non-glandular component, and the glandular component have this peripheral zone and the central zone and the transition zones are there. Why they are important? Because the transition zone, which is the inner gland, is the site of a BPH nodule, which causes enlargement of the prostate and which causes the symptoms of urgency and frequency, and because of which we receive TERP samples. And this transition zone cancers generally are there. If there is a cancer, then they are very low grade and the volume is also low and they have a good prognosis. However, this peripheral zone, which is the outer one, so have a clinical significant cancers, and that is why we can use the needle biopsy for getting the samples. So again, what is the problem in this prostate? Why we are breaking our head? Because first is localization of the tumor is very difficult. Second, there may be a small tumor foci which may not be there if we have given small foci, and it can not be there in the radical specimen or vanishing tumor syndrome. And reporting subjectivity, now it has come down, but still if you get review section slides, you still get 2.2+2 or 3+2 reporting. So if we see the history of how it is developed, the first one is the original which was there by the Gleason score, and then how it has changed. So it looks like this. Now all the only discrete well formed glands are there in pattern 3. Pattern 1 and 2 are not to be reported. The minimum pattern which you have to report is 3. All the 4 consist of everything. All the glomerular pattern, the fuse, cribriform pattern, everything has been included in 4. And 5, again it is sheets or accommodate necrosis is there. And the other things which was added in the last WHO was the prognostic grade grouping, which because when patient was given a report of 6, which if you see in out of 10, it is more than average, and patient was asked for active surveillance. So patient used to question them, when I have a tumor more than an average, why should I go for active surveillance? I will go for active treatment rather than. So that is why. So this grade group was made by Dr. Epstein, and so this group, if we say the patient is group 1 and the worst grade is group 5, then the patient says, okay, I am in group 1, so I will definitely go for active surveillance, which is less aggressive, very slow growing and low risk. So that is why it helped a lot in the patient, because in the West, Dr. Epstein and the group which I have been trained under, they used to give a lot of notes after the report, and they used to tell that this is a very low grade tumor. So that note has not been written now. Just they give a low grade tumor, the grade group 1. So patient understand, okay, I am in a grade lesser group and I will go for active surveillance. So this is the main history behind making this prognostic grade grouping. So when I came back to India, I validated this WHO's new Gleason score. Maybe I was little biased, but still I was able to study some 143 cases, and 8%, almost approximately 8% cases were upgraded in this study. So before going into the how to gross the specimen, you should always know the stage of the tumor, like how it is staged. So staging of prostatic carcinomas starts from T2 only, and which is organ confined, and then again according to the extension of the tumor, T1, T3 and T4 are given. That was the major change. The major change which occurred from last WHO was earlier it was T2 as where 1/2, more than half was there. But now they have removed T2 A, B, C, and now they have put only T2 only. So if it is organ confined, means more than half, one lobe involved, both lobe involved, everything comes in T2. So this is the major change which occurred in 8th edition, and rest all were same. So So why? What are the peculiarities? Because Gleason score along with PSA level, this is the nice guidelines which are used in UK, and the clinical stage depend upon the PSA level, Gleason score, and the clinical stage of the patient. So these are the patients are risk. The stratification is there. If patient have a low risk, then again patient will go for a active surveillance, and depending upon the level of risk, the patient treatment will be there, will be given. So again, before going into the grossing, you should know what are the clinical findings which are relevant to the patient, and what is the clinical context, and what is the type of specimen. We'll see how many specimens are there. So information about the prior biopsy and resection is important, and helps in interpretation of microscopic findings within the appropriate clinical context, whether low volume, low grade is there, and any treatment has been given, anti-ADT treatment has been given, because it may alter the cytology and architecture of both benign and malignant glands, and therefore may alter the significance of grading. And this is the most important, radiotherapy, because patient may undergo radiotherapy. So date of starting of the radiotherapy, when the radiotherapy has been stopped, whether it's a brachytherapy has been given, what is the date of insertion of the seeds, and all that information is very much required. So what are the specimens we get in prostate? The biopsies, it can be transrectal, transperineal, the TURBs, enucleations or simple prostatectomies, radical prostatectomies, and lymph node removals can be the same. So again, biopsies mainly for diagnosis and getting the score and the grade of the prognostic grade, and they are performed when there is an elevated serum PSA levels, and if there is an abnormal DRE, and usually it is performed via 18 gauge needle, and it can be transurethral or transperineal. So what are the different kinds of biopsy which we see? It can be a sextant biopsy, it can be an extended biopsy, or it can be a saturation biopsy. Sextant biopsy is the widespread biopsies which is used. It is sampled bilateral, base, midgland, and apex. The extended biopsy can be used as an initial diagnostic procedure, and it demonstrates increased cancer detection rate without increasing morbidity. False negativity rate is approximately 5% as compared to 25% in section biopsies. So, and in what is saturation biopsy, where there are more than 20 cores. Basically, it is not an initial procedure, and when there is a persistent elevated PSA level and we are finding a negative biopsy, so then it is done, which also include the transition zone. So again, while handling the biopsies, it's very important to count and document number of cores. Ideally, if they have separated, they have sent in different containers, you have to give in different cassettes, and the usual formalin fixative is used. And basically, hemotoxin or any dye can be put on the tissue core to make it more visible, and 1 to 2 core section per block to minimize the tissue representation should be done. So again, more level, the tissue may deplete. Then if you use many cores, then it becomes a mix. The tumor is lost. So level 1, 2, 3, as the experts say, 1, 3, and 5 can be used for HNE, and unstained levels can be used for the ISC if they are required. Ideally, 3 sections should be present on each HNE slice to enhance the 3-step sections, as the experts say, and most of the tissue in the block from the superficial to deep should be included in the section. In our institute, we received this extent biopsy. So this we have made a form. It gives a tabular form. So we record our grossing findings here, and we record our tumor histology. So when you are recording it, some points to write are what is the histology, where adenocarcinoma, S in our NOS, the modified, I call it because this is the modified Gleason score, the prognostic grade group 1 to 5, percentage of tumor in the core is important, and percentage of pattern in 3 plus 4 or 4 plus 3, percentage of 4 is also important, and LVI PNI. So basically now the concept of global grade is also coming, because we leave it to the clinician to find out which is the grade. So basically if there are 12 cores, so basically we can give an average score, final average score, and a final average grade, which will help the clinician rather than just leaving to the clinician. So this is how we record our findings. So final score 4+3 and final grade is 3. So percentage of 4 and percentage of the total tumor is also been given. FNAC and cytology rarely perform and basically it educates, it's cheaper, faster, easier to use. Major drawback is lack of architecture, so you cannot differentiate between a pin and a Gleason's grading you cannot give. And touch imprints may be useful in immediate reporting, and they can provide immediate and reliable cytological diagnosis of prostatic carcinoma. Basically because they are rapid and highly suspected cases and abnormal PSA levels are there, then we can use it. So TURP, the transurethral resection of prostate or subtotal prostatectomies is a surgical choice for BPH, and open simple prostatectomies may be performed for bulky BPH, and it includes the transitional zone as we discussed earlier and areas around the proximal prostatic urethra. So incident of prostatic cancer encounter is approximately 10%. We have also seen incidental cancers which are found in TURP biopsies. And sometimes, because ours is a cancer hospital, we receive TURP not for BPH, we receive mostly for the relieving of the symptoms. So I tell my PGTs, don't break your head for the Gleason score and don't try to fit in many blocks. So we have to submit up to 12 blocks. But again, it is the institutional policy. If you are able to sample the TURP adequately, then accordingly you can give the sample. And if there is cancer is present, then we have to submit the entire tissue for the proper assessment and volume of the tumor. So enucleation and resections, they do not, basically these are, they don't require prior sectioning, and they are generally restricted to large prostate in patients and lower urinary obstructive patients. And a few incisions in the biopsies may allow formalin fixation, and inking is not useful in this case. Usually they are processed as a TURP. So now coming to the radical prostatectomy. So again, as I told you, any large specimen, fixation is important. The weighing of the specimen is important. Orient the specimen, ink it and serially slice it, and peculiarly we have to submit it entirely in prostate. So radical prostatectomies are performed after when there is a documented carcinoma on renal biopsies, prostate biopsies, and there are numerous protocols for submitting, either ranging for submission entire specimen in whole amount or to limited sampling using standard slide. So whatever method you are using, we have to evaluate the extent of the carcinoma, grade, stage, and the margin status. So you can do entire, or you can do a partial sample in a systemic fashion where you can give the different sections. So again, so if you see, when we receive the total result, we usually do get a robotic specimens done by robotic surgery, and so you can either inject with formalin, or you can keep it in a jar with 1:10 ratio. Then again, orientation is very important. Again, you can put a probe along the apex, so you can identify the apex, base of the tumor, the anterior bulging part, the posterior flattened part is there, and the seminal vesicles will be there. So you have to identify the organs, and the proper inking should be done. So you, after identifying the apex, base, the right lateral, left lateral, anterior, posterior, you can just ink it in different colors. Many people ink in black, only one color also. It is depend upon the institutional protocol. So separate the seminal vesicle, weigh the tumor, and size and weight of the prostate. Size is very important because it is inversely proportional to high grade cancer, advanced disease, and greater risk of progression after radical prostatectomies. Therefore, they may be important prognostic variables post-operatively to predict biochemical progression. So how to do it? Now section cut specimen, how you cut up. So first what you do is the apical margin, you just amputate a 4 mm thick cone, as you see in the first upper figure. You just amputate it, then lay the section flat on the board and cut into left to right half through the urethral orifice. So just bread loaf it, and bread loaf it, and then you have to submit it edge embed, because then if you see that ink is there above, and you have to edge embed the specimen, and then you have to do the serial slicing. If you do a whole mount, you see, so you can see the margins are there very nicely, and you can cut the specimen. Then again the bladder neck also serially slicing, you come to the bladder neck, again amputate at a 3 mm slice, and then include the entire bladder margin and mucosa junction. Bread loaf same like apex in 2 mm into and submit at edge. So like this you have to submit, right and left you can submit it separately also. So this is the edge embed. Seminal vesicle also same, amputate the seminal vesicles and from transversely section from base to each semen near the junction with the prostate. So this is the whole mount section which we cut, and this you can see the first section is the apex, which is edge embed, amputate and embed edge embed. These are the serial sections, and this is the base, and these are the seminal vesicles. Again, proper labeling should be done. So we use whole mount, but you can earlier before I think 2017 when we didn't have robotic and mega slides, we were using this 4 sections you can make, but you have to just label. You can just make it half, you can make it 4, 6, 8, whatever, how many sections you want, depending upon your own ease. And but you have to label them properly. You have to grid it if you want to, and label it properly. So this is these are the mega cassettes we have. So it makes our jobs very simple when we have to see 70-80 slides as compared to 5-6 slides. So these are the keto sections, and you give the apex margin, the serial section, the base, and the seminal vesicles. So these are the mega slides which we get. You can see clearly we have edge embed these the apex and the base and the serial slices there, and better localization of the tumor can be there. So this is how we record our findings, like specimen, what are the specimen we have got, and then again we see what is the size of the specimen, weight, and seminal vesicle size, and then specimen what are the colors which were in, and the specimen is sliced from apex to base and submitted entirely. So these are the findings, gross findings, and then the final report is you have to write what are the histological type, adenocarcinoma, adenocarcinoma, the modified Gleason score, prognostic grade group, the involvement of the tumor of the prostate, LVI, PLI, extension, extra prostatic fat extension, whether it is focal, non-focal, and if there is a higher grade tumor, that also you have to mention. Bilateral seminal vesicle involved or not, you have to mention, and the margin including the base and apex, you have to mention whether involved or not. So quantification, how to report it? Quantification is done by simple eyeballing. So you have to just see the serial section, and you can mark it microscopically, and then you can just use your marker pens with better marking of this. So extra prostatic extension, it is basically tumor is going out of the prostate, but it does not necessarily means that the margin is positive. It is just going, now you can see in the below figure, now ink is there and the tumor is going into the fat, but and here also ink is there, but it is going into the fat but does not go into the margin involvement is not there. Again, as I told you that what are the location, which location it is positive, number, and focal versus non-focal you have to mention. Bladder neck invasion, again it is defined as neoplastic gland above the level of benign glands in the thick muscle bundle are called as bladder neck invasion. So, and it is a very important factor because it is a significant predictor of PSA recurrence and is considered a category of T3A. And seminal vesicle involvement, again it can be by direct invasion. It is also have a adverse prognostic factor, and it can be direct invasion or extra prostatic or involvement along the ejaculatory duct or discontinuous involvement. So intraprostatic seminal vesicle is not considered as involvement, but however this you can see seminal vesicle which is extra prostatic, that only involvement is included in the definition of involvement. So again, margins, as I told you, apex and base are the problematic areas where fat is less. So that is why we give edge embed there. And then again, what are the it should be entirely submitted, and it should be mentioned whether how what which are the margins are involved. And negative if it is not present as inked margin. Positive if tumor cells touches the ink margin. But you have to be very careful in telling the margin positivity, because by cutting the tumor, you may take out the fat also, and it can be a false positivity. So definitely you have to just you have to make sure how the tumor cells are reaching the ink may have seeped in to the adjacent tissue where the fat has been removed. So you have to see the entire section and decide accordingly. This is what I was telling. The prostatic should not be interpreted as extra prostatic extension, and intraprostatic margins are positive in setting of intraprostatic or capsular incision. We have seen more than 100 robotic cases, robotic surgery where they had been done, and only I think one case where the surgeon already informed that it is a R2 resection and they have cut through the tumor. It was a very bulky tumor which was going into the bladder and all. So usually we get a good margin, and so this is not a problem, but you should be very much aware of it. Whenever there is a discrepancy, talk with your surgeon. Don't straight away give there is no tumor or their margin is positivity or like that. So any discrepancy, so that is why I'm saying you have to think like a clinician, and accordingly, if any discrepancy is, talk with your surgeon and treating physician. So margin, what is the length of the positivity, focality and location where it is, and margin positivity is there in extraprostatic extension also, and what is the location, and the descent pattern should be so told. So these are all the points you should look, and this is the new the microphotographs which has been made by Dr. Epstein himself. He tells that how in this era of digital pathology, how can we use a schematic diagram of lesions. So he has made it. This is also available in in Hopkins website. So you can just find out, and you can just follow it. You can keep it in your desktop, and if you have any problem, you can just see it in different patterns. What about ISCs? So mostly I don't use ISCs. Even if there are some atypical small glands, then we can use ISCs. And as you can see, the most specific one is NKX 3.1 and prostine. We have done a study on prostine also, and it is a very good marker, and it is more specific, and it can be expressed unrelated to the Gleason score. And PSA and prostine, and these are all also most sensitive markers. So one point of caution I want to tell to all the PGTs is, do not upgrade from suspicious outpouching of HG based on your positivity of MCAR, because MCAR can be positive in high-grade pin also. So just only one section you are seeing and MCAR is positive, don't go that, oh, this is a carcinoma. And do not downgrade a cancer to suspicious or suspicious to benign basis based on the negative MCAR staining. So take-home messages, again, clinical details, radiological findings, prior diagnosis and IC if done, localization and size of the tumor, margins and capsular amount, and most important here is inking of the specimen. So I have two interesting cases. One is this is reported by me and my senior colleague. And this is a 60-year male, and patient presented with bleeding PR and constipation, and he had a circumferential growth in the rectum, and again there was a mass in the rectum, which was and he had a PSA, raised PSA of 6.4 units, and both biopsies from the rectal lesion, we thought it is a prostate going into the rectum or rectum going into the prostate, so we did biopsies for both. The rectal biopsy was very it was suggestive of adenocarcinoma, well to moderately differentiated, and but the prostate biopsy showed a lot of inflammation, and a lot of these changes were there. And then we looked at the higher power. They were looking not a mixed population but a monotonous population, and I consulted my senior hematopathologist also regarding these cells. So we did AMCAR earlier and it was negative, and P63 highlighted the benign glands, and then CDX2 was also. We thought it be just a poorly differentiated adenocarcinoma from rectum, but CDX2 was also known. So basically these are inflammatory cells, monotonous. So let's go for LCA. So LCA was very much diffusely positive in this case, and CD3 was background. 20 was very much positive in this. Other markers were 10, B cell 2, 23 was very nicely positive, and 5 was focally positive. So Ox was also focally positive. Here was little bit on the higher side. So it was given as diagnosis of low grade B cell non-Hodgkin's lymphoma favoring a small cell lymphoma. However, the PS peripheral smear was showing no atypical cells, and bone marrow aspiration biopsy was also no involvement. So it can be, it accounts for 0.1% of all NHLs and 0.09% of all prostatic tumors, and age is very broad and symptoms may be same as BPH, and usually prostate is non-tender and not as hard as a carcinoma. And these lymphoma, studies have been done, and CLL and mantle cell commonly occur as a secondary involvement, and CLL and SL occurring as a primary if not reported. So, because generally known to have indolent codes. It's another case of a 50-year-old male, and he had a mass. He underwent a urethroplasty in 2015, and despite the urethroplasty, symptoms did not because he had a difficulty in micturition. So underwent suprapubic catheterization, and he was habituated to smoking tobacco and consumption of alcohol. And PR, they could palpate a prostatic mass. So radiologically there was a prostatic mass, and then patient underwent a biopsy prostatic lesion, which was inconclusive because there were haphazard cells, some spindle cells, like that it was there. So radical prostatectomy was done with the resection of the bulbar urethra and bilateral pelvic lymph node dissection. So this was a mass which we received. A large prostatic mass was there, which was around 8 into 7 centimeter, and mass was adherent to pelvic floor muscle inferiorly endopelvic fascia. These are the OT nodes, and the plane with rectum was well maintained, and bilateral lymph nodes were there. So this is the specimen which we received. This is the prostate. This is the bladder. If you see the cut section, bladder looks normal, and this is the prostate. So we submitted the entire prostate, and this is the kidney which we got, and similar morphology was there in the biopsies also. It's very high grade, looking like a very high grade bizarre cells are there. The round to oval cells are there. This is the high power view. So we thought it is a spindle cell neoplasm, maybe a sarcoma high grade, maybe a leiomyosarcoma, rhabdomyosarcoma, or inflammatory myofibrillus. So these were our DDs when we started, and then we did AMCAR for baseline, and then we did SMA. Cal Desmond was totally negative in this case. Myogeny was negative. So other markers which we did is pancytocrotin desmin, CD117 dog1, which were negative, and expression of the NI1 was intact. So again, we relooked our these slides, and we saw these spindle cells and with vesicular nucleus, moderate amount of cytoplasm mixed with numerous multinucleated in bizarre forms, and mitosis was discerned. We did CD34, which was positive with these tumor cells, and these are the tumor cells. PR was positive. AI was also positive. So the IC survey, if you see, we maintained CD34, PR, and focally SMA, and KI was around 30%, and other markers were negative, and INA was intact. So if you see the chart, and it was a non-epithelial prostatic spindle cell lesion, and we labeled it as high-grade stromal sarcoma of prostate, which was rendered. So this is the final report which we gave. Stromal sarcoma high grade, 9 centimeter tumor with 90% involvement of the prostate, and the other findings which were negative. So as soon as we released the report, we called the call from the clinician, what is this? And so we also searched the literature. So we found out this table where they have 15 cases, 15 cases were there, and what were the treatment, adjuvant chemotherapy and radiotherapy was given in this patient, and what were the response time, and what is the outcome of these patients. And we in the tumor board discussion was there, so we advised surgery with adjuvant chemo RT. So patient underwent prostatectomy as in 2015 and followed by 6 cycle of chemotherapy till 2016 March, and followed by 50 day of radiotherapy in 25 fraction for 5 weeks till August 2016. And if we see that these tumors are uncommon and comprise of 0.7% of prostatic tumors, and in contrast to stromal sarcoma tend to affect a slightly younger patient with a range of 25 to 86, and approximately half of the reported cases occur before 50 years, and they may arise de novo or may exist in association with a pre-existing concurrent stump. So we check the recent advances, and ISC studies in the present case supported the diagnosis of stromal sarcoma. However, it is reported that role of ISC and other ancillary techniques are limited because of less numbers, and there are no approved molecular tests for this. However, study indicated that overexpression of P53, P16 and MED12 gene mutation may imply a poor prognosis, and 17q duplication and increased prune2 protein expression may show a favorable outcome. So surgical intervention, chemotherapy, radiotherapy as a treatment modalities in this, and 5-year survival is 44, and as no biological parameters such as elevated PSA for monitoring is there. So absence of metastasis and clear margins have a positive bearing on long-term survival. So patient close attention to the morphological detail in conjunction with IC is a key to make diagnosis in this case. And we published this case in Indian Journal of Surgical Oncology in 2017, and with 30 months of follow-up in 2018, patient was now admitted for anemia because he had HB of 9.2, and definitely the tumor, there was no new tumor at the site of the previous tumor bed, but patient developed therapy-related myeloid neoplasia. So follow-up is required, and what I want to give this message is that your role does not end just at the diagnosis. So your inputs and all are required, because any new diagnosis you give to the clinician, they will ask what to do next. So we have to find out what are the things, what are the treatment we have to give, and you have to follow it up. And patient ultimately developed therapy-related myeloid neoplasia after 3 years of treatment. So that is my time. So before ending, I just want to thank Dr. Nadeem and Dr. Divya Madam for giving me this opportunity. I also want to thank my staff, my HOD, Dr. Sushila, my Professor Sundaram, and my colleagues and my PGs who are attending this. Thank you, sir.
Wonderful. Thank you. There is one question, and that is from Dr. Rekha Singh. I will read the question as it has been written. ASAP, as soon as possible, sir, please talk about atypical small acinar proliferation. So please, sir, talk. I can understand. This is a real dicey thing.
Yes.
Everybody is so much worried about this small acinar proliferation, tumor or no tumor.
Yes. So this is a very important aspect of reporting of prostate. I usually don't do ISCs on prostate biopsies because ours is a tertiary cancer center. So we have the we have the privilege of getting bad tumors. We don't get early tumors. So, but many a time reviewed outside and very small in percentage, we say that it is a atypical small acinar, and we try to do limited biopsy, like you can do MCR in P63 and you can see those those glands. If still they are not if their problem is not solved, so what you can do is you just can talk with your clinician. There are few glands, and then again, PSA level is important. Another clinical staging is important. So those things comes into account, because it is not absolute that in biopsy diagnosis have to be given, because as I told, practical problems, localization is difficult. If it is a small tumor, it is difficult. So that those points you have to take into account. So whenever you get a small this focus of these cells, try to do this epithelial marker and myoepithelial marker you can do. If that problem is solved, okay. If not solved, talk with your clinician. Patient will be kept under follow-up or repeat biopsy will be done.
So Dr. Rekha Singh, is it okay? Are you happy with the reply? There is a comment on the YouTube which I would like to read out before Dr. Rekha Singh responds, which is by Dr. Sai Malikarjun Sitaram. Says tissue monoclonal lymphocytosis can occur in prostate without blood involvement. Yeah, that's right.
Pure.
Yeah, pure prostatic lesion.
Yes, yes.
So that is also an entity which has been defined, although it puts you into a lot of confusion. But that also has to be kept in mind in all these monoclonal round cell lesions. Right, Dr. Sambit, if he would like to say something, Dr. Sambit Mohanty, would you like to say something? Okay, we're not getting him. I think we have. Just let's wait for a minute to see if there's any question on the YouTube. So Dr. Rekha Singh has a comment. She says these are similar expression IHCs as adenocarcinomas.
No, if they are tumor, then they will have. If they are not, then they can be a pin also. If it's a high grade pin also. So it depends upon the expression of IHC. It does not necessarily. If it is a benign thing, if it is a low grade pin, benign thing won't show up. Because AMCAR will be produced by high grade pin and adenocarcinoma both, but the myoepithelial markers are the key here. So P63 basically, if you see in the West, they use a pin 4 marker, in which P63, the two markers, high molecular weight cytokeratin and P63, both are used in a cocktail. And AMCAR is pink, and both the myoepithelial markers are brown. So if you try to do a cocktail marker like that, or if you do it separately also, you have to find.
Right. Dr. Mohanty?
Thank you.
Yeah, exactly. Atypical small vascular proliferation is usually a problem. Once in a while, we all get it. And what Vishal just said, you have to go for a pin 4 cocktail. Look at the myoepithelial, because if you use only one basal marker, you may miss out. It's better to use CK903, high molecular cytokeratin, and a nucleus stain like P63. So, and here I would give more importance to the basal marker rather than the AMCAR, because AMCAR can be produced but positive in like fibrotic area, sometimes benign gland and pin and all this thing. So if we see like your staining is not like cancer cells, there is loss of basal cell and the volume is low and other cores are negative, so it makes a phone call with your clinician saying it's a low volume cancer, the rest of the cores are negative and probably a repeat biopsy is required. If you, after doing the staining, you have one or two or very little distinct basal cell, but you are saying some AMCAR positivity, and these are small glands, non-pain glands. Pain is a big gland disease. So in that scenario, you also need a phone call because it might have unsampled cancer, low-grade cancer somewhere. So either way, a telephone call to the urologist is important unless the stains don't behave.
Yes.
In that case,
when your morphology and stains are not helping, better to leave it like that only. Don't break your head on that, and talk with the clinician, and accordingly he will say, okay, this is a low grade tumor, so better we'll follow it up and put in active surveillance. If it's a high grade tumor or more spreading one, we'll see accordingly.
The PSA value is important, and usually these lesions do not have a very high PSA. They have usually a borderline PSA. So that also helps. And just to add on the prostatic stromal sarcomas, and Vishal already mentioned in his slides, there is no magic marker. The markers are pretty changing. The typical morphology helps, but the cases with high Ki67, and I mean, they need to be followed up because they tend to develop all these paraneoplastic syndromes or metastasis. And to exclude the true sarcomas of the prostate, I mean the other sarcomas of the prostate.
Let's wait and see if there's any more questions or any queries.
Paramita madam wants to say something.
Yeah, Paramita is here. I just saw her name.
So Dr. Paramita, please unmute your mic and say something if you have any comment to make. I don't think so that there is any more questions. We have thank yous in the YouTube channel. Everybody's appreciate. Yeah, Dr. Kataria, you want to say something?
Hello, sir. Dr. Sant is my senior from my college and a very good person, my guide also. So thank you, sir, for attending. Yeah. Yes.
Yeah, hello, Vishal, how are you?
Yes, sir. Fine.
It was nice to hear you from after a long time.
Yes. Yes.
It was a good date indeed, a good information regarding both kidney as well as the prostatic biopsy and all the immunohistochemical markers which are important for differentiation of different type of renal tumors.
Yes.
One thing that I was asking in the previous talk,
Yes.
that usually we do not get renal biopsies very frequently for the non-neoplastic and neoplastic lesions. We usually have renal biopsy from the nephrology department.
Yes, medical. Yes.
Nephrology department.
Yes.
Especially for the glomerulonephritis and all other chronic renal failure.
Yes.
Usually our surgeons, because renal biopsies we do not receive very frequently. We have very few renal biopsies.
Yes.
Which are done
Sir, for the publication of paper, we have seen many.
Not aware all these.
Yeah. We have done many studies also, sir, and we have seen also studies where now biopsies are included for renal because to differentiate clear cell and non-clear cell, because treatment protocols, when there is a very aggressive tumor which has been disseminating tumor, so they want to know whether it is the clear cell or non-clear cell, and again. For non-disseminating also, they may give, if they can give any prior treatment to the before the surgery, maybe shrinking of the size and all, when there's a big tumor.
Yeah, now renal biopsies are coming up for like.
And any experience of.
Yeah, for few reasons, like if it is like a non-clear cell high-grade morphology, that time they want to do, and the tumor is already metastatic, they want to start some new adjuvant therapy. Particularly for the eosinophilic ones with high-grade morphology, they want to triage out maximum tissue upfront for some genetic markers so that some therapy can be given before the debulking happens. Or non-clear cells one, even if they are organ confined, they usually have a lot of molecular players. They want to check it beforehand and do new adjuvant to shrink the size and then go for a nephrectomy. And also Priya has Dr. Priya Rao, a good friend of mine, Priya has a study on, it's kind of ongoing, looking at PD-L1 expression on the core biopsies.
Yes. We are doing PD-L1 whenever asked. Mostly they are doing in when there is a disseminated disease or metastatic.
Exactly, metastatic setting. Metastatic setting is already there in the NCCN.
Yes.
Dr. Paramita would like to...
Vishal, one more.
Sure, sir. Boliye, sir.
Any experience of Hale's colloidal iron to differentiate between oncocytoma and chromophore type?
Yes, sir. We have done. Even in my first case, which I saw was in Tata only, where we did a hair colloidal iron, and it really helps. It really helps.
Dr. Paramita?
Because
Yeah.
many centers they do not perform immunohistochemical staining, so
Yes,
it is
yes.
one
We
of the
have to
special
acquire,
stain which
we
can
have to acquire
benefit.
that. It is very helpful. Not that much
Yeah.
cumbersome.
Recently,
Yeah.
recently one case was referred from Central Hospital,
Yes.
Delhi, to us, and they were not having any markers.
Yeah.
So we try to do some other markers along with the Hills colloidal, which came very beautifully in the
Yes.
chromosome type of
Yes. It
renal
really
cell
helps.
carcinoma. So this, really, it's very nice to hear you from us. Good.
Thank you, sir.
Thank you.
Thank you.
Dr. Paramita, please.
Yeah. Vishal, excellent talk. I just had a comment regarding small SNR cell change and in fact prostate cancer in general. That what I find useful is using two basal cell markers rather than Amaker, which sometimes gives very wishy-washy staining. I can't really use it very confidently. So using two basal markers is really helps, like a P63 with an HMWCK or CK56, and that actually prevents overdiagnosis of small SNL cell change or misinterpreting prostate cancer. So,
Yeah. If
Amaka,
Dr.
I don't
Rekha, if
find
you are
very
getting
useful.
many cases, you could better to buy a pin 4 marker, where, as Madam said, it will have P63, HMB45, HM not HM, high molecular weight cytokeratin, and MCAR. This the combination will be there, so it will really help.
And
Yeah,
actually,
again,
AMBER should never be interpreted in the absence of a basal marker in
Yes.
any scenario, even if it is not atypical. What Paramita said is very correctly. Amacar is a very dicey stain,
Yeah.
and unless your morphology is not supporting, Amacar alone is not going to do any magic.
right. And more than pin 4, I actually like the stains on different slides because it gives you more levels. So that
Yeah,
helps with prostate. So I'm
yeah,
not a fan of pin 4 at all.
Yeah.
yeah.
Yeah. Thank you, ma'am, for the comment. Yeah.
Right. So, is there anything more? Anybody else would like to make a comment? Any? I don't. Let me just check up in the YouTube. No, there are none. So I think we will call it a day.
Yes.
Thank you so much, Dr. Vishal, for such a wonderful, extensive, and elaborate presentation. And you really slogged it out. 200 slides. My God, you really have some stamina to teach, and you really taught us so well with highlighting the points which are very important, right from the grossing part to the immunohistochemistry, and also picking it up from case point of view, showing us cases where things are applicable. So it was a real good, collection of everything, a very nice teaching material. And since we are having all this up on the YouTube channel for everybody to view, so this becomes a very good platform for people to learn. Thank you so much, Dr. Vishal, for contributing in the teaching process. And I would like to thank all and everybody who were present here, Dr. Mohanty, Dr. Paramita Roy, Dr. Kataria, and Dr. Rekha Singh, Dr. Suhasini Naik, and there are so many people on the YouTube, Dr. Aditya Sinha, Gunjan Gupta, Malika Arjun Sitaram, to name the few, and the ones whom I haven't named, please don't mind me. Thank you so much. We'll see you soon with Dr. Vishal with part 2.
Yes.
So what's happening? We are waiting. So
Lot of
that's it.
lot of things are
A lot of
happening.
things are happening. Yeah, true.
And I'm containing myself because the WHO, the work is going
The
side by
secret
side.
act of WHO.
Yeah, so it will
Yeah,
be.
God, wish you best of luck for that. Thank you so much for taking out time. Thank you everybody for joining in. Bye bye. Good night. God bless everybody. Good night. Take care. Bye.